Good evening and welcome to the webinar on recent advances in cancer management. I would like to invite our first speaker, Dr. Sudipta Bandopadhyay. Over to you, sir.
Thank you, the entire organizations, and for giving me the short presentations of the latest trial, and that is BAFE with atezolizumab with a good chemo backbone, FolfoxIri. That is your one phase 2 randomized trial, that is Atezo trial study. So before going to present the trial, only brief description of this trial is it is unresectable or metastatic CRC. This is a very important topic for every medical oncologist and very difficult to handle for a surgeon also. So unresectable to resectability and controlling the metastatic burden is very important job. So initially, BAFE with chemo backbone is a good weapon. So adding atezolizumab, that is a anti-PD-L1 with doublet chemotherapy, that is oxaliplatin irinotecan can use, or it will place anything extra. So this is the main purpose of the study. Show me the slide, please. So this is the inclusions of the criteria. Already I told you, histological foveal adenocarcinoma, unresectable MCRC, or whatever it is, a metastatic MCRC, measurable disease, age 18 to 75, good performance status, and patient not usually prefers any sorts of chemotherapy and no contraindication to the immunotherapy. So one arm is your chemo backbone, that is your FolfoxIri with BAFE, and another arm, that is arm B, that is your Folfox with BAFE. So arm A, Folfox with BAFE up to XL, and other arm is BAFE with Atezo. So these two arm is there. So after good inductions, there is a maintenance therapy. One arm is the 5FU leucovorin with BAFE, another arm is 5FU leucovorin and Atezo. And if progressive disease is there, then reintroduction with this another regimen. Primary objective for any this trial is PFS, and another secondary endpoint is your safety and tolerability. So next slide, please. So the main one of the most important agent is how safety this regimen is, because Folfox is a toxic regimen. Adding BAFE is also toxic little bit of, and adding atezolizumab. So if we see the Folfox with BAFE and Folfox with BAFE and Atezo, the number of the patient, one is 73 and one is the 145. Definitely the toxicities are definitely in favor of BAFE Atezo. But if you see the exact toxicity, not p-value is not significant. So the toxicity had, but that toxicity is not so significant. This is number one. And number two, if you add atezolizumab with your BAFE with FolfoxIri, definitely some immune related toxicities are there. So that is also a very important thing. Next slide. Now, this is one of the most important thing. If you add efficacy results, so primary endpoint, if you see the BAFE Atezo with chemo backbone, your PFS is improving compared to only BAFE arm. So that improvement, how much? That is 13.11 versus 11.5. Hazard ratio 0.69, acceptable p-value 0.012. So p-value also significant. So your PFS that is showing that the BAFE with Atezo with chemo backbone, it is producing some good amount of PFS benefit. Next slide. Now, this is also a very important thing. If you see the response rate, but this is one of the most important thing. The response rate are more in favor of only BAFE arm compared to the Atezo, that is 64% versus 59%. And if you see the resectability, it is 37%, 26%. So adding a atezolizumab with BAFE will not carry any extra marks. So now there is improvement in median PFS rate, but your resectability, your response rate, nothing is improving. Next slide. Definitely, if you see the subgroup analysis, your deficient MMR analysis, as any immunotherapy backbone, the deficient MMR group, the PFS is significant. That is, if you see the PFS rate, that is your 6.6 versus not reachable. So deficient MMR, primary subgroup analysis, adding atezolizumab, the PFS data is good. Next slide. So the hazard, next slide, if you see the another arm, so one is your deficient, another is your proficient or presence of MMR. If you see PFS data is also improving, but that improvement is not much. 11.4 compared to the 12.9. Hazard ratio acceptable, p value 0.071. So in both arm, proficient arm, deficient MMR, adding atezolizumab will producing good amount of PFS data, but that is more insignificant of deficient MMR compared to the PMMR. But this significance of PFS benefit is not so much in PMMR group. Next slide. So my conclusion is very important thing. The primary endpoint, that is addition of Atezo to upfront folfoxIri with BEV, prolonged PFS in a molecularly unselected MCRC patient, hazard ratio 0.69 and 0.012. And if you see, no difference in RECIST response rate and no safety issues were observed. The important thing is that overall survival data still not mature. And last important thing, the magnitude of the PFS benefit was heterogeneous according to the MMR status. That means in the deficient MMR subgroup, impressive results were reported with folfoxIri with BEV and Atezo. Median PFS not reached at a median follow-up of 20.6 months. In PMMR subgroup, the addition of Atezo still provided a statistical significant benefit according to this initial result. So unresectable or metastatic colorectal cancer, if you add atezolizumab with BEV with folfoxIri, will produce no extra added benefit in terms of your resectability or response rate. Yes, it producing some good amount of PFS benefit if you see mostly in case of BMMR group. But that is not a very good thing, because in BMMR group, you add any immunotherapy, it will produce a good amount of toxicity. In presence of MMR, the PFS benefit is a little bit improvement, but the entire result is very heterogeneous, very clumsy. And if you see the toxicity, yes, the toxicity are more in favor of your BEV atezolizumab compared to your only BEV arm. But that toxicity is acceptable, that toxicity is tolerable. Yes, the immune-mediated toxicity definitely in case of atezolizumab. So the entire study is my point of view, if you add Atezo with BEV with folfoxIri will not carry any extra added benefit. Thank you.
Thank you so much, sir. I would now like to invite our next speaker, Dr. M.V. Chandrakanth. Over to you, sir. So you'll have to unmute yourself.
Yeah, thank you. So I'm disabled to share.
Sir, I'm sharing the slides if that's okay with you.
I mean, I should keep saying next, no? If you share.
Okay, sir. Sure, sir. I'll just forward you.
Yeah. Just hold on.
So you can try sharing now.
Okay, is it okay? Visible?
Yes, sir. So if you could just make it perfect, sir.
Okay. Okay, I'm audible and I'm visible, right?
Yes, sir.
Yeah, okay. Okay, so well, at the outset, I would thank Dr. Reddy's, and I would also thank Kavina Creations to have a smooth organization of this update. And it was an excellent presentation from Dr. Sudipta. Well, in coming 10-15 minutes, I will speak on the lung cancer updates from the ASCO, the recent ASCO 2021. So these are the 4 trials I'll be bringing in. Number one is the code break study that speaks of sotorasib in KRAS G12C lung cancer, and then the Pacific 5-year update post CTRT, then the CheckMate 9LA 2-year update, and the FDA pooled analysis. So let us go into the code break 100 study. So this is the code break 100 study. So we know KRAS constitutes nearly 40% or 50% of non-small cell lung cancers. Among that, majority of the KRAS mutant patients are smokers, and only 13% out of the 60 or 450 we have, G12C is the only susceptible subgroup of KRAS mutation where we have a drug that is sotorasib to target only this particular subset. So the way we have exon 21 or exon 19 deletion in EGFR, similarly in KRAS we have PG12C. This is the only subset that is amenable or which is druggable. So well, if you, this is basically a phase 2 study that looked mainly into the response rates. Roughly, if you look into the progression-free survival is half a year and overall survival is nearly 1 year. So this is what the figure we have, but these are all in pre-treated patients, not in fresh or treatment naive patients. So if you have a pre-treated patient and you are exposing these patients to sotorasib, that is a specific G12C inhibitor, you would expect a progression-free interval of half a year and an overall survival of 1 year with a response rates around 35%. This is what the take-home message for sotorasib code break. So we had keynote, we had checkmate, we had point break for bevacizumab. Here we have code break for sotorasib. So this is how it is. The dose is 960 milligram once daily, and CNS mets were excluded. Active mets were excluded. And the primary endpoint was overall response rate. So just to summarize, G12C KRAS, 13% adenocarcinoma, 90% patients are smokers, 960 milligram once daily is the dose, sotorasib is the drug, it is specific for G12C KRAS mutation, PFS around half a year, overall survival is 1 year. Along with this, two coexisting mutations have to be remembered, STK11 and KEAP. STK11 present mutation in KEAP is absent, it's a good subset, whereas both mutated bad subset, KEAP mutated bad subset. So STK11 present, KEAP negative, good subset. Side effects, diarrhea and LFT derangement. So similar thing I'll just say, majority of smokers and majority were heavily pre-treated and nearly 90% of them had received PD-L1 or PD-1 therapy before. So these are the responses. You have nearly 37% responses. This is basically in the subsequent line, heavily pre-treated, not in the front line setting. 960 milligram once daily is the dose. And the median overall survival is around 1 year is what we are seeing with sotorasib. So, well, this is about the baseline characteristics. Again, heavily pre-treated, and these are irrespective of PD-L1 expression, there is a response. Irrespective of tumor mutation burden, there is a response. But you need to just remember about STK11, the same gene responsible for Peutz-Jeghers is here. It's a tumor suppressor gene. So if STK11 is mutated, KEAP is wild, in that subtype, you're seeing a good overall survival crossing 15 months. Whereas if both mutated, it is bad. And if it is KEAP mutated, it is bad. So the take-home message is what I said. The slide which I showed, just simplified. G12C KRAS 13%, 90% smoking history, 960 milligram OD, sotorasib is the drug. Median overall survival 1 year, STK11 and KEAP have to be looked before targeting KRAS mutation, and diarrhea and LFTs are the side effects with sotorasib. Okay, I think so. We discussed at least one data of KRAS G12C mutation, and now we will go for the Pacific 5 years. I think we all know about the Pacific study. Durvalumab is the first IO approved in the post-CTRT setting in the stage 3 unresectable lung cancer, non-small cell lung cancer. The hazard ratio is 0.68 with an excellent p-value for both overall survival and progression-free survival with an excellent safety profile. Here we have a 5-year follow-up of the same data. So we all know the baseline, how the design of the trial is there. Durvalumab 10 per kg 2 weekly for up to 1 year. So this is the 4-year follow-up data. You can see the overall survival is 4 years. 5-year follow-up data, the median overall survival is 4 years, something like an ALK TKI, the way we are seeing such a dramatic improvement. So 47.5 months is the median overall survival, almost reaching 4 years versus 2 years if you are not doing immunotherapy post CTRT, almost doubling of overall survival, and the hazard ratio is 0.72. Practice changing, and we must recommend durvalumab to all patients who complete CTRT. Otherwise, you have a short PFS and a short OS. If you want a durable overall survival, the way to go is durvalumab post CTRT. Excellent 5-year overall survival, median overall survival reaching 4 years. And you must always remember the tail of the curve, how the curve becomes parallel to the baseline as you keep following these patients. So the conclusions are 5-year overall survival 42.9% and 5-year PFS 33.1%. Very well tolerated. Now they are exploring options for combination with chemoradiotherapy along with other chemoradiotherapy regimens, and after chemoradiotherapy in combination with other agents is what they are looking at. So that is about Pacific study 5-year update. Now we will speak on CheckMate 9LA 2-year update. We all know Nivo-EP chemo. A brief duration of chemo in the first 2 cycles did improve overall survival irrespective of PD-L1 expression. This is the background of CheckMate 9LA, and this is how the trial is having the initial 2 cycles of chemo along with Nivo-EP. Later on, only Nivo-EP continues. So just to remember, 360 milligram 3 weekly, ipilimumab 1 milligram per meter square 6 weekly will continue, and the chemo was there only in the initial 2 cycles. Remember, Nivo-EP is going to continue until progression or up to maximum of 2 years. Well, nothing much to say about the trial. It was a positive trial with a median overall survival nearly 15.8 months in all randomized patients. I would just request you to draw your attention towards what is known as never smoker. Never smokers didn't do that great, but smokers did extremely well. CNS mets did very well. Squamous subtype did well, and PD-L1 less than 1 also did well. Therefore, we recommend CheckMate 9LA for patients, especially if the PD-L1 is absent or less than 1, squamous subtype, brain metastasis. And in never smokers, we need to think of it. And we need to look at driver mutations. So this is the updated 2-year progression-free survival. Again, difference is there, irrespective of the PD-L1 subgroup. Safety, the toxicity is there only in the initial 2 cycles when it is chemo IO. The moment chemo is taken away, IO is reasonably well tolerated. So the conclusions are 2-year overall survival, a significant, excellent CNS activity, irrespective of PD-L1 expression. Squamous histology acts very well. Of course, both the histology did benefit, and good safety profile. So that is about CheckMate 9LA 2-year update. Coming on to the pooled analysis, PD-L1 1 to 49, IO versus IO chemo in non-small cell lung cancer. Well, in PD-L1 more than 50%, we have 2 options: pembro mono, Altezo mono. PD-L1 less than 50%, we have pembro chemo, Altezo chemo, we have ABCP, Nivo-EP, and CheckMate 9LA, which I spoke. These are the regimens that come into my mind when, as per the PD-L1 expression in non-small cell lung cancer. The usual comparison in all clinical trials is IO versus chemo or IO chemo versus chemo. There is not much comparison of IO versus IO chemo. This is what the trial has done. If you go back to keynote 042, PDL1 more than 50 versus 1 to 49. Pembro mono did not do that well. The hazard ratio is 0.69 for Pembro mono if the PDL1 is more than 50 versus it is not significant if it is 1 to 49. Therefore, if it is 1 to 49, Pembro mono is not the way to go. So if it is 1 to 49, IO mono is not the way to go. So they used a pooled analysis of they did not take the individual patient data, but they took the results of multiple clinical trials. And this pooled analysis is useful when the results of individual studies do not give a firm conclusion. So it did include 8 randomized controlled trials, 2 RCTs, had Pembro mono and Nivo EP also. Both PD1 and PDL1 inhibitors were included. So they looked for PD1 on tumor cells only, but not on immune cells. It was a comparison of IO chemo versus IO, which is not usually addressed in clinical trials, and they looked at PFS and OS. So they had 2,100 patients, PDL1, 1 to 49. 12% were above 75 years, and 85% were smokers. And the median follow-up was 1 year. Well, if you look into the results, IO chemo did better than IO in terms of progression-free survival, 7.7, 4.2, and the overall survival was also better, 21.4 versus 14.5 months in the subgroup of 1 to 49 PDL1, IO chemo versus IO. These are the results of pooled analysis of the results of multiple randomized trials. These are not individual patient data. The authors themselves conclude that these results presented are considered exploratory and hypothesis generating. So, well, if you look into the 2 specific subsets of more than 75 years and never smoker, in this subset, it did cross unity and was not that greatly significant. So, well, the conclusion is chemo IO may improve efficacy outcomes over IO alone. This is what the authors concluded in the subset PDL1, 1 to 49%. So, well, the pros of this study is it has a unique comparison of IO chemo versus IO, which is not done in clinical trials. It is a big study, a big pooled data of the results of 8 randomized controlled trials having 2,000 odd patients with the profound endpoints of overall survival and progression-free survival. However, it was a pooled analysis of results, but not the individual patient data. So in the conclusions, they have used words like may exploratory hypothesis generating. This is what they've used. It would have been better if we had an IPD meta-analysis. However, this is what we have. So, well, to conclude the pooled analysis in the subset of PDL1, 1 to 49, IO plus chemo is the way to go. IO mono is not the way to go. In the subset of PDL1, more than 50%, IO alone may be the way to go. So the challenges with IO mono is the concern of early progression. Therefore, even in patients who have a PDL1 more than 50%, if the disease burden is high, even in that subset, we may use IO chemo. This is what the expert comments from the author of the trial. So with this, I think I have summarized all the 4 clinical trials. The first trial saying that code break G12C, best way to go is sotorasib, specific 5-year survival, and the median overall survival crossing 4 years, CheckMate 9LA, persistent benefit even in PDL1 negative squamous and brain mets. Pooled analysis says if the PDL1 is 1 to 49, the way to go is IO chemo and not IO alone. So with this, I would thank everyone for your patient listening, and back to you for organizers.
Thank you so much, sir. I would now invite our next speaker, Dr. Tanmoy Mondal. Over to you, sir.
Hello, am I audible now?
Yes, sir. Perfect, sir.
Okay, so good evening, everyone, and thanks for giving me this opportunity to Dr. Reddy's and team. So I will be talking about the current role of anti-angiogenics in the era of PARP inhibitors. Next slide, please. So yes, what we have in the last 6 years around, we have coming near about 10 to 12 new approvals, mostly of them being the PARP inhibitors, the rucaparib, the olaparib, the niraparib. Also comes into the picture the use of chemo plus bevacizumab in the platinum sensitive ovarian cancer as the maintenance in first line, maintenance bevacizumab as the first line in first line ovarian cancers as a maintenance in this, and also in the platinum resistant subset also chemo plus bevacizumab. So there are about 6 new approvals regarding this ovarian cancers in ovarian cancer in the last 6 years. 12 new approvals. Next slide, please. So PARP inhibitors, which has been approved for ovarian cancers, what we know that yes, olaparib, rucaparib, and niraparib, all 3 have been approved for treatment in ovarian cancers. Next slide, please. So this is the era of targeted therapy in ovarian cancers. What we see that yes, the targeted agents, mainly the PARP inhibitors, and also comes bevacizumab based on the targeted olaparib, which comes based on as the maintenance in based on the trial solo trials, solo 1 and solo 2. Rucaparib comes from the Ariel 3 trials, and niraparib comes from the Nova trials, and the bevacizumab, what we come to know about is the Oceans, the Aurelia, and the GOG 218. Next slide, please. Next slide, please. So yes, so what I will be talking about today is the anti-angiogenic therapy in ovarian cancers, the mechanism of action, anti-angiogenic agents, the phase 3 trials of bevacizumab leading to regulatory approvals, and the combinations and recent studies regarding this. So first comes the anti-angiogenic therapy of ovarian cancer, the mechanism of action. So mechanism of action is the mitogen tumor secreted permeability factors, which was which came in 1993. A mitogen for endothelial cells. The key survival factor for endothelial cells is the activating PI3K kinase and the AKT3. And due to the permeability which is present during the ascites, this impacts the tumor cell proliferation and invasion. So regulatory effects on the immune surveillance are also seen by tumor-associated macrocytes and Tregs. So what we see that the survival of the patients with invasive ovarian cancer based on the preoperative serum VEGF levels, what we see that it was significant. Next comes the anti-angiogenic agents. Next slide, please. Next slide, please. So angiogenesis was a target near about 9,000 patients with ovarian cancers were studied in different trials, and mainly the VEGF ligand was used, anti-VEGF agent known as the bevacizumab was used in mostly the GOG, the ICON trials, the Aurelia, Oceans, and the Oceans trials. These were the trials in which around 9,000 patients were used angiogenesis as a target. Next slide, please. So in patients in all the settings, it has been used as a frontline maintenance in the platinum sensitive, in the platinum resistant, and the recurrent subtypes. In all the subtypes with prior use of anti-angiogenic been used, and it has been seen to be effective in all. It has been seen that there is a progression-free survival and all in almost all the trials which have been seen. Next slide, please. So next, what will come is the phase 3 trials of bevacizumab leading to the regulatory approval. Next slide, please. So the era of targeted therapy in gynecologic cancer has arrived, which is a humanized monoclonal antibody against VEGF receptor. It is used in platinum-resistant recurrent ovarian cancer as per the Aurelia trials. It is used in platinum-sensitive recurrent ovarian cancer as per the Oceans trial, and in newly diagnosed stage 3 and stage 4 ovarian cancers which are suboptimally debulked, or if there is ascites predominant disease, there also we prefer the use of bevacizumab in newly diagnosed cases. Next slide, please. So first comes the Aurelia, which is a randomized open label phase 3 trial in which was used in the platinum-resistant ovarian cancers, there were two subsets. Its randomization was either a paclitaxel-based or a topotecan or a PL for pegylated liposomal doxorubicin, and was randomized to bevacizumab at 10 milligram per kg IV every 2 weekly or 15 milligram IV every 3 weekly plus chemotherapy versus chemotherapy alone till progression. It was seen, and what we saw that the all baseline characteristics was well matched, and what we see that the main outcomes was PFS, which was taken into account, and the secondary outcomes was overall response rate and the overall survival. Next slide, please. So what we see is that the objective response rate, which was significant as per the RECIST criteria in the RECIST responders, what we see that with bevacizumab plus chemotherapy, almost all of them had a good objective response rate in the form of a serological response, in the form of a radiological response, clinical response. All the three things we had a good response rate. Next slide, please. Yes. So next slide, what we see is that in the Aurelia trial is the progression-free survival and the overall survival. What we see that in the progression-free survival, the median PFS was 6.7 months in the bevacizumab plus chemotherapy arm, whereas it was 3.4 months in the chemotherapy alone, which was clinically significant with a p-value of less than 0.001, with a hazard ratio, unstratified hazard ratio of 0.48. Whereas the overall survival, what we see that the overall survival was not clinically significant. It was 16.6 months in the bevacizumab plus chemo arm, whereas it was 13.3 months in the chemotherapy alone arm with a p-value of 0.174, which is not clinically significant. So next slide, please. So as per the PFS and the response by cohorts, what we see that yes, in specific cohorts, there was some better benefit in the weekly paclitaxel plus weekly paclitaxel cohort, which we see that the response rate was much better than in the other cohorts, PLD and the topotecan arm. Next slide, please. Next slide, please. So next comes the Ocean trial, which is phase 3 randomized trial of chemotherapy plus bevacizumab in the platinum-sensitive ovarian cancer. In almost all the recurrent platinum-sensitive with a platinum sensitivity of more than 12 months, either if both the patients, both the subgroups were used with a platinum-free interval of either 6 to 12 months or more than 12 months in the both subsets which were used. After randomization, they both to randomize to both bevacizumab and chemotherapy, with bevacizumab at 15 milligram per kg IV every 3 weekly for 6 and up to 10 cycles as a maintenance, and bevacizumab monotherapy followed by bevacizumab monotherapy with 15 milligram per kg until progression or unacceptable tolerance, whereas in the control arm it was placebo plus chemotherapy. Next slide, please. So the Oceans, what we see that the grade C4 adverse events, which we saw, the 4th month increase in the median PFS was there, which was significant in the 4 months. So next comes the GOG 213, which is a randomized phase 3 trial of chemotherapy plus bevacizumab in the platinum-sensitive ovarian cancer, in which bevacizumab was used at 15 milligram per kg every 3 weekly for 6 and up to 8 cycles, whereas in the previous trial it was up to 10 cycles. And then a bevacizumab maintenance till progression. It is the main efficacy outcome measure was overall survival. Additional outcome was progression-free survival. Next slide, please. Please. Next slide. Yes. So this is the GOG 3 overall survival results. Previous slide, I think it has gone a bit one more. So what we see that yes, the overall survival main efficacy outcome which was seen is that 5.3 months increase in the median overall survival was seen in the paclitaxel carboplatin plus bevacizumab arm, whereas it was with a hazard ratio of 0.84. Next slide, please. Next comes the GOG 218 study design, which was launched in January 2000. It was completed in January 2018 with paclitaxel plus carboplatin in one with 175 milligram and AUC 5, AUC 6, and the second arm being paclitaxel carboplatin plus bevacizumab initially, followed by placebo, and another is with
Tanmoy, sir, can you hear us?
So next slide, please.
Sir, can I request you?
Yes. Is it fine now?
Yes, sir. So can you please stop your video, sir, so that may faster.
Okay, right.
Yes, sir.
Okay, right. Okay, so next slide, please. Yes, so this is the primary endpoint of the GOG 218 study, the chemotherapy, paclicarbo and the paclicarbo plus bev, and the another one is paclicarbo plus bev followed by bev maintenance. But we see that giving maintenance in the first line setting had a significant progression-free survival of 14.1 months versus 11.2 and 10.3 in the other two arms. Next slide, please. So this was the censored for CA125, where we see that in the FDA approved PFS analysis, also the median PFS was in the paclicarbo plus bevacizumab followed by maintenance was 18.2 months versus 12 months in the only chemotherapy arm, with an hazard ratio of 0.62, which was significant with a p-value of 0.001. Next slide, please. So this is the final analysis of overall survival in this and BEV throughout versus control. So BEV initiation versus control. So what we see that in the BEV throughout versus control, what we saw that the hazard ratio of 0.95 was observed without a significant p-value of 0.49, and also in the other arm also it was not a significant p-value. Next slide, please. Next slide, please. So this is the 10-month overall improvement in the stage 4 disease. What we see is a subset analysis in the overall survival. We had in the stage 4 disease, FIGO stage 4 disease, if we use bevacizumab in the upfront setting, we had seen that there was a 10-month overall survival improvement in the stage 4 as per the FIGO stage. Next slide, please. So this is the updated PFS and OS data of the ICON 7 trial. Next slide, please. So yes, the key studies in establishing angiogenesis as the treatment target for in ovarian cancers. In the first line, we have the GOG 218, in which chemo versus BEV initiation versus BEV throughout was used, in which the endpoint was PFS. So BEV during and up to 10 months after chemotherapy prolongs the PFS. So in ICON 7, what we see that chemo plus minus BEV, also BEV improves the PFS, but OS not significant. OS was not significant. So next comes the Oceans trial, in which also what we saw that chemo plus minus BEV improves the PFS, but OS is not significant. The GOG 213 also BEV improves the PFS, but OS is not significant. And also in the Aurelia in platinum resistant subset, what we see that BEV improves the PFS. So in almost all the trials, there was an improvement in the PFS by using of bevacizumab as an anti-angiogenic therapy, rather than their overall survival, which was not seen. Next slide, please. So next we see the combinations and the recent studies. Next slide, please. So we will quickly go through this. These are certain newer trials of combination agents, what we use. So this is the study design first of the FIGO, in which randomization was done to the standard platinum-based chemotherapy versus the experimental arm as platinum-based chemotherapy plus bevacizumab. Next slide, please. The PFS investigator associated primary endpoint, which was seen in the combination arm, was 11.8 months versus 8.8 months in the median PFS in the chemotherapy alone arm. Next slide, please. The hazard ratio of PFS by major subgroups, which was seen that in the experimental arm fared better, in which the bevacizumab was used in the experimental arm. So in almost all the things, as per the age, less than 65, more than 65, with a performance status, the bevacizumab had progression after first line, completed or ongoing, platinum-free interval, and chemotherapy backbone. In almost all the subsets, the bevacizumab had fared better. Next slide, please. The overall survival also, it was seen that it was 26.6 months versus 27.8, which was not significant. Next slide, please. So the response rates, which we saw in the experimental arm, the response rates was in the tune of, in the CR and PR was seen in around 65 to 70% of the patients in total, whereas in the standard arm, it was around 60% of the patients in the standard arm. Next slide, please. So next is the anti-angiogenic therapy in the ovarian, some other more trials. Next slide, please. So the results from the Imaging 050 GOG 3015 and NGOT 0 OV39, a double-blind placebo-controlled randomized phase 3 trials of bevacizumab containing therapy plus minus atezolizumab for newly diagnosed stage 3 and stage 4, which was presented in the ESMO in 2020. Next slide, please. So the trial design, there was cycle 1 to cycle 6 consisting of paclitaxel carboplatin at the standard dose plus bevacizumab, and for cycle 7 to cycle 22, and another was combination was paclitaxel plus carboplatin with bevacizumab plus atezolizumab at 1200 milligram every 3 weekly. So these were the stratification criteria: was stage 3, stage 4, performance status, treatment approach, adjuvant versus new adjuvant, and the PD-L1 status was either less than 1% or more than 1% in SP142 Ventana platform. Next slide, please. So the progression-free survival in the Altezo plus chemotherapy plus bevacizumab was 19.5 months versus median PFS in the placebo plus chemotherapy plus bevacizumab was 18.4 months, and the hazard ratio was 0.92, and it was not significant in this arm. Next slide, please. So the overall survival also in the first interim analysis, it was not evaluated median overall survival in almost both the arms. So next slide, please. So next comes the role of olaparib plus bevacizumab as first line maintenance in ovarian cancer, the PAOLA study. Next slide, please. So the PAOLA study patient study design was 802 patients were enrolled in the trial with a 2:1, with receiving bevacizumab plus olaparib or bevacizumab plus placebo for up to 2 years. Stage 3, stage 4 patients were used. All patients underwent MyChoice testing. 48% of women were MyChoice positive, whereas 30% of women had a tumor with BRCA mutation, while 18% were BRCA wild type but HRD positivity. The primary endpoint was PFS. Next slide, please. So yes, here comes the results of patients in this PAOLA study. So patients with a tumor with BRCA mutation, olaparib plus bevacizumab had a good overall. This was the progression-free survival in these patients. In the olaparib plus bevacizumab had a better progression-free survival, whereas in the patients with HRD tumors without a BRCA mutation was a bit lower. Next slide, please. So the summary and conclusions were that bevacizumab is a first approved targeted therapy in gynecologic oncology. Earlier use of therapy and maintenance are two most important strategies to maximize the clinical benefit, and significant benefit in HRD subset with added olaparib was seen in the trials like PAOLA study. So these are the conclusions. Next slide. So this is all regarding the today's topic, current role of anti-angiogenics in ovarian cancer. So this is all regarding from my side, and thanks for this opportunity. Thanks.